Today I'm going to talk about the integrated spring mass model and approach to the treating of thoracic outlet syndrome. Now, the integrated spring mass model is a model of biomechanics that describes the body as an integrated spring. In the past, the body's been described as a lever mechanism. So what I've determined in the last 15 years is that the body actually moves as both a spring and a lever mechanism. However, there isn't any good information out there about how to examine and treat the body as a spring. And what you're going to find out is that when I outline for you how we treat the body as a spring, you're going to find that it's actually superior to treating as a lever. Thoracic outlet syndrome, we're having a difficult time with it. It's one of the most underrated, overlooked, and misdiagnosed conditions in medicine. In fact, medical professionals say it's the most important peripheral neuropathy in the upper extremity, and it's one of the most difficult to manage. Some people say it's underdiagnosed. I do. Some people say it's overdiagnosed because they don't know how to diagnose it. And sometimes it's just misdiagnosed or not diagnosed at all. People go on forever, for years, and finally someone says, could it be thoracic outlet syndrome? Majority of doctors are just confused about thoracic outlet syndrome and leaves the patient in the middle. The thoracic outlet is composed of three passageways. One in the scalene triangle. It's called the scalene triangle because it's between the scalene, anterior scalene, and the middle scalene, and the attachment on the first rib. The second location is right under the collarbone there. And as the blood vessels and nerves pass through that tunnel underneath the collarbone. And the third location is called the subcoracoid space. The coracoid process is here, the pectoralis minor attaches to it, the biceps short head, and the coracobrachialis. All three of those muscles attach on the coracoid process, and the nerves and the blood vessels go underneath that. And so you have, a lot of people now getting thoracic outlet syndrome. When I first started writing my book, it was only about 35,000 people were searching for thoracic outlet syndrome on the internet. And now 74,000 per month in the United States alone are searching for thoracic outlet syndrome on the internet. And the Nielsen, what's driving this is that Nielsen statistics tell us that the average American is spending 11 and a half hours manipulating gadgets and looking at gadgets with their arms and their shoulders, and that's just way too many contractions. In fact, sustained contraction of muscles is what I feel is the primary cause of thoracic outlet syndrome. Thoracic outlet syndrome has a history. It was one of the first surgeries ever performed in 1821. The first rib resection was in London, and it was one of the first surgical procedures. So the surgical removal of the first rib resection has been done for over 100 years. The other problem with thoracic outlet syndrome that confuses everyone is it has so many names, like thoracic outlet syndrome, NTOS, that's neurologic thoracic outlet syndrome, ATOS, which is arterial thoracic outlet syndrome, VTOS, which is venous thoracic outlet syndrome, disputed thoracic outlet syndrome, Paget-Schroeder syndrome is kind of like thoracic outlet syndrome, but much worse. And so it's got a lot of different names. The cause of thoracic outlet syndrome, as outlined on the websites for Baylor Heart and Vascular Hospital in Texas, Johns Hopkins Hospital, and Washington University School of Medicine, the common word is the word compression. So what you have to understand is in the spring mass model, the muscles are the only structures that can actually compress the body's spring. The shoulder itself is actually elevated over the tunnel, so it is the roof of the tunnel. And the muscles of the trapezius and latissimus dorsi actually suspend the shoulder over the tunnel as the roof of the tunnel, and the rib cage is the floor of the tunnel. So if the scalene muscles are pulling, lifting the first rib up into the tunnel, the tunnel is getting narrower by the floor of the tunnel raising up into the tunnel, and then the roof is falling into the tunnel at the same time. So that's why you have this compression of the blood vessels and nerves. There are 16 different treatments that are outlined in PubMed. The reason why I know this is because I've read over 2,500 articles on thoracic outlet syndrome and taken copious notes, and I've listed them, everything from medications, scalene injections, non-steroidal anti-inflammatories, painkillers, scalene injections from Botox, stretching, traction, nerve gliding, ultrasound, muscle stimulation, different support bras for women, and ergonomic corrections of your workstation, for your computer, massage, adjustments, exercise, and strengthening. Which one of those actually shuts off the muscle tension that squeezes or pulls the bones into the thoracic outlet by themselves? None of them. Together, you can say, if you have the right combination of those, you might have good luck with thoracic outlet syndrome. But I'm going to tell you, the main problem is that if you don't do a good job in conservative treatment, find a good doctor or apply the right treatment, you might end up having surgery. The surgery is done for about 10 different reasons. If you just can't stand the pain, some patients beg to have the first rib removed. Like, they think that you can just say, well, cut the pain out of me. I can't stand it anymore. Anything is better than what I have now. And that's not true. You can't cut the pain out of the body. And when you do surgery, you're not guaranteed that you're going to be better. You could be worse. Neurologic deficits such as numbness in the hands and the arm. Limb threatening when the arm looks like it's needing to be amputated from a lack of blood supply. I don't think you're going to see that very often. Arterial compression. The hands are cold. If you have a blood clot or thrombosis, after you have a blood clot in the subclavian vein because of the blockage, you might have clot busters injected into the vein, and then after that they may do a decompression, which is surgical removal of the first rib, resection of the scaling muscles or cutting them out, and also the pectoralis minor muscle that attaches to the coracoid process. Also, Paget-Schroeder syndrome is where actually the clot will be in jeopardy to be released into the bloodstream. It goes then into the heart, and then it will transverse into the lung from there, causing a pulmonary emboli or a stroke in the lung called a pulmonary infarct. That's very severe, and it's not impossible to get it. I mean, it happens. It's rare, but it has happened, and you definitely don't want to just take medication and just get through it and bear through it and live with it. You really need to do something about it. Also, you might have a failed surgery from thoracic outlet syndrome that you may need to have operated on again, and maybe surgery is done for the wrong reasons. But the main reason is because your conservative therapy did not work. And the surgery outcomes are, some doctors are bragging about them, but the literature says differently. But basically, there are 4 different types of thoracic outlet syndrome. I don't really think about this. You know what? Here's the problem. You have neurologic thoracic outlet syndrome, which means in this bundle of vessels, the nerve is pinched first, the neurologic. Then you have venous thoracic outlet syndrome and arterial thoracic outlet syndrome. In reality, the thoracic outlet is compressed, so any given day it could be that the nerve's compressed, one day it's the vein, sometimes it's the artery. What you really care about is that you want to find out why it's compressed and the source of the compression and remove that. That's more important. And so the symptoms are mostly like pain up here in the neck, and then after that you feel tingling in your fingertips. Usually it's non-traumatic, which is good because it rules out a herniated disc. If you have a herniated disc, that usually comes from trauma. Some people say, I had an MRI and I have a herniated disc, when you have to have traumas. These herniated discs may be 15 years old and not the source of your pain. And that's why you should not jump into an operation for herniated disc. After you feel these tingling, what happens is that when the ribs rise up into the T1 nerve root, it can actually clip off more nerves as it gets higher and higher. So then you're going to see the tingling move from these two fingers, the fourth and fifth digit, to the seventh, or to the middle finger, then across to the thumb. One of my patients was a piano player for Smokey Robinson, and he said that when I asked him, he said he had diabetic neuropathy for 5 years, and he's on disability. He can't play piano anymore. And I said, how did the symptoms start? He said, here, and it went this way. I said, you do not have diabetic neuropathy, because that starts distal and goes proximal. So in fact, I was right. He was misdiagnosed by 3 of the top neurologists in the nation, and after we got to treat him, he actually recovered and was able to play piano again. So some of the craziest signs I've seen is pitting edema in the arm, where the forearm has pitting edema from the fluid buildup. The symptoms can be in one arm or in both, and if you have tingling in both arms, or if you have symptoms in both arms, then it's more likely to be thoracic outlet syndrome than a herniated disc, because the herniated disc usually goes to one side and not both. I've never even seen only a central herniation, but I've never seen tingling in both arms from a herniated disc, and that's 32 years in practice. This is usually what it looks like. So now we're going to talk about how I examine the body, the thoracic outlet. First of all, how is the body designed? We have to understand how it's designed. How is it engineered for these 4 functions? These 4 functions cannot be explained by the lever model. So, number 1, how is it engineered to protect itself from impacts during walking? How is it engineered to recycle energy, like running marathons? How is it engineered to provide spaces for joints? Anyone ever think about that? How is it engineered to allow the safe passage of blood vessels and nerves through these spaces, like the thoracic tunnel or the carpal tunnel? This is the area we want to look at the most. How is the mechanism controlled? The nervous system actually controls the tension on the body spring and on these passageways. So the nervous system can control the tension on the spring. If we step down from a curb, we know exactly how much tension to put on the spring to land safely. If we're jumping from 3 feet up, we may know exactly how much tension to put on if we want to land safely. Imagine the difference between when you're tumbling on a mat, like at the Olympics, and you're tumbling, you want to get great height and you want to get great movement, so you know to use the spring to bounce, but at the end, in the corner, you have to stop suddenly, with your dismount, and then you cannot step back out of the area, because if you do, you get a point taken off. So we put different tensions on the spring for different reasons, and that's normal. These are the models that we're comparing it to. The inverted pendulum model, which is 340 years old, that doctors use mostly, they don't realize it. The spring mass model, which was proposed by Harvard researchers in 1989 and 1990, and then my integrated spring mass model, which means that the Harvard University model just modeled the legs as linear springs. I actually modeled the spine and the human body as a torsion spring, and also modeled the feet, the arch mechanism, as a suspension system spring. So these are the models of biomechanics. The first one, the inverted pendulum model, says that we reach out with a straight leg like a pole, and then we use our back leg to push the mass over this straight leg like pole vaulting. And so when this happens, you should see that if you put a sensor on the side of the body, you should see that the sensor would go up, but it actually goes down. So they couldn't figure out why, and the spring mass model figured it out that the sensor goes down because we're loading energy, we're loading the mass or the force of the impact into the spring. And then you have the lever model of exercise, or the lever series of treatment. And back years ago, 20 years ago, to look at the body as a lever mechanism was considered, the standard state of the art, or the highest level of knowledge. Now that's old knowledge. And what that means, like, we're using levers to lift weights, like doing a curl extension, but what about plyometrics? So the lever model was popular with bodybuilding, as we know. Joe Weider, Arnold Schwarzenegger. In fact, when I was a young doctor, doctors told us not to lift weights because it can enlarge our heart, and that's not good for our health, and then we found out that was wrong. And most of the people that pushed for that were not doctors, by the way. Though that was people like Joe Weider and Arnold Schwarzenegger and the bodybuilding movement, Bob Goldman. And so I studied under Yuri Veroshansky. I ran the first sports medicine course in the former Soviet Union. Ed Cohen was my patient. I made some trips to the Soviet Union as his doctor, competing against the Russians in powerlifting. And also I ran my own powerlifting competitions with Fred Hatfield, Dr. Squat, back in the day. In 1987, 88, and 89, I ran the first sports medicine course in Russia. I had bought all the Soviet sports reviews, which were the accumulation of the knowledge from the journals in Russia that were translated to English by Dr. Michael Yesis. And then what I did was I selected the top doctors from those journals from 1966 to 1986, and I presented that list to the Russian Sports Committee, and they called Dr. Ed Enos, who was also co-organizing it with me, and they said, how does he know who our experts are? Basically, the spring mass model is lacking, that it does not include the foot, just from the ankle to the knee to the hip, and it does not include the spine or the head. In the spring mass model, the human body is a torsion spring in my model, and the head is the mass. The foot arch is a leaf spring, and the tendons are extension springs. The head sits precariously on a spring as the mass, and the thoracic outlet syndrome is designed with spring engineering. In fact, like when you see somebody tackle somebody with the shoulders, with this incredible impact into the shoulder, but it's built like a bumper with a spring mechanism that it bounces down just far enough not to hit the blood vessels and nerves, and then it bounces you off of the impact if it's working right. And athletes get stingers when they have the nerves pinched, but that doesn't happen very often. So the shoulder girdle is suspended over the first and second rib of the rib cage as the roof of the thoracic tunnel. The first and second ribs are the floor of the thoracic tunnel, and they're actually suspended by the scalene muscles. There are no muscles that pull the ribs down. The nerves pass safely under this roof of the tunnel, which is the shoulder, and over the ribs. And this tunnel is maintained open by spring engineering and not lever series. Hooke's law of physics governs how strong the spring mechanism is and how its ability to stay open. And Hooke's law of physics, or the law of elasticity, says that you have if the spring can store as much energy as it is depressed. And in this case, it is an extension spring. So it can store as much energy as it extends. So given that you can have a stronger spring or a weaker spring, like a spring in your pen has a very low strength compared to one in your car. And so what we can say is that if we want to build stronger outlet, open the outlet, we would want to do shrugs, because the extension spring does not allow the roof of the tunnel to dump its weight into the thoracic tunnel. So you have the suspension system muscles, which are the trapezius and the levator scapula muscles. And the cause of compression, which is muscle tension, is the cause of a lot of conditions like headaches, neck pain, upper back pain, herniated disc, painful herniated discs, median nerve compression, cubital tunnel in the elbow, low back pain, degenerative discs, degenerative joints, herniated discs in the lower back. So the nervous system controls the tension and on these discs and on these openings by way of a normal tension or pathological tension. The spring system has a certain capability of either being compliant, which is it can, where the muscles around the spring allow the spring to load deep, or it can be stiffer, which means the muscles are tense around the spring. Now, when you're jogging, you have a compliant spring. When you want to race, you tighten up the spring and you ricochet off the ground faster. And so the muscles actually, what they do is they don't push you forward, they actually just tighten the tendons to allow a tighter spring so that you can bounce off the ground faster. So muscle stiffness is not the same as spring stiffness. That's different. So I wanted to qualify that. Now, where we can get into trouble, and the most trouble for thoracic outlet syndrome for patients, is with posture. Now, Sir Sherrington did some study on posture, and what he found was when we tilt the body to one side, the head actually stays perpendicular to earth. So if I lean to the one side and my head leans with it, then I fall. If I want to balance while I'm leaning, I will leave the head perpendicular to gravity as a counterbalance, and that's done automatically for you. How did he determine that? He cut the connection between the learning center, or the cerebellum, and the midbrain, and then he put animals through these different positions to see how they would react, and in fact they reacted. They had the same reflex action, so they found out that even though they cut loose the cerebellum, it can't be a learned activity, it had to be reflex. So it's done for you. And then the person that took over from him and took that knowledge and wisdom and created a coursework for athletes and entertainers and dancers and doctors was a fellow by the name of Alexander. And that was Alexander technique, was a technique of posture. So you have the posture equilibrium, which is the same tension around the spring, no extra tension in any of the areas of the spring, and then the orientation is how the bones stack up on top of each other. And so the sensors of the body actually will determine this posture. So what you have in the brain or in the skull is the semicircular canals. They're on this plane, that plane, and this plane. And they're like hula hoops with thousands of hairs inside them. And on top of those hairs is a gel material and some crystals. So when you lean to the side, the gel material slides with gravity, trips those hairs and trips those nerves, and then it actually processes it in the brain, and then it tells the muscle on that side to contract to compensate for my leaning. So if you're leaning back in the bed watching TV, you'll have scalene contractions on both sides. So you'll have a bilateral thoracic outlet syndrome if that's the cause of your tension that's compressing the outlet and the nerves. If you have it on one side, I can just guess what side of the couch you're sitting on, and patients get a little alarmed when I know exactly what side of the couch they're sitting on. They think I'm looking in their window. So the writing reflex, or the labyrinthian writing reflex, is where the reflex that gets us, that is good for us. So you have pathological tension and normal tension. Pathological tension is when the muscles below the shoulder, like the pectoralis minor, subclavius, costoclavicular, and bicep short head, drag the roof of the tunnel down in the outlet, and the tension from the scalene muscles lift the ribs up in the outlet. Also, you have weakness. If the shoulder is weak from the traps being too weak. Women don't want to have a strong neck, big neck, so they end up with thoracic outlet syndrome. As a matter of fact, when they have surgeries, like studies, if 500 people are getting surgery for thoracic outlet in the study, 400 of them are women and 100 of them are men. So the pathological muscle tensions in the anterior scalene, the middle scalene, the posterior scalene, and the subclavius for the neck area and the ribs. The subclavius muscle, not only does it pull the rib up, but it also drags the shoulder down at the same time. The pectoralis minor, anterior deltoid, bicep short head, coracobrachialis, latissimus dorsi, and the lower trapezius muscles drag the roof down into the outlet. So the theories why this becomes chronic is because when you have muscle contraction constantly, it throws lactic acid out, it lowers the pH of the area, and the acetylcholinesterase, which is the enzyme that breaks up the acetylcholine that creates the muscle contraction, it's not as effective with the low pH. So part of the treatment has to be sweeping the lactic acid out. And also, the second theory is that the inflammation is so soaking the area so much, these muscles, that the nerves, the nociceptor nerves, pick up on the chemical changes in the muscles, and that will create a problem where the brain says, well, there's a problem there with the inflammation that's being detected, and so we have to tighten it up. It's called splinting, and it keeps it constantly circuiting around, so you end up in chronic pain. You could end up in chronic pain for the rest of your life, as a matter of fact. Postures that create this problem are sleeping postures, sitting postures, if you're sitting, to the side, or if you're leaning back, or both, or holding up a bag. Like if you hold a bag on the right side, you counterbalance that weight with tilting your head to the left side. So they've got the pressure from the bag on the right, weakening your trapezius muscles, and then you've got the pressure from the tilting of the scalene muscles on the opposite side. So basically, when we're looking at thoracic outlet syndrome, doctors will say that you can have an extra rib in your neck area, a cervical rib. The problem is that if you're born with it and you've had it for 25 years and then you get some symptoms of thoracic outlet syndrome, they say it's that rib that's going up in the tunnel. Well, you've had it for 25 years, so how could it be that rib when you were fine for 25 years? So that's usually not the case. So you need a second opinion on that. And car accidents can cause thoracic outlet syndrome from the whiplash of the scalenes, and also work injuries. The most important examination you could do is when you actually palpate these muscles to see if they're sore or not, and then also manual muscle testing like Adson's test, Ruse test, and hyperabduction maneuver are some of the tests, as well as Cyriac's test, costoclavicular maneuver, and cervical rotation lateral flexion test. I'm not going to go over those tests, but hyperabduction maneuver involves the lift elevation of the arm above the head to the side and taking the pulse. Now, if your arm goes numb, then they say that's positive. Well, then when the arm is down, they say if it goes away, then it's still positive. The problem is that when you lift your arm up like this, the pectoralis minor, if it's tight, it'll drape around the blood vessels and nerves, and it'll cause these symptoms. So all it could be is just a pectoralis minor spasm that you're detecting. Also, these diagnostic tests like the venogram, when you're doing the venogram and they ask you to lift your arms up and they see that there's no blood in this section of the vein during that test, and then they say, well, there's blockage, but when you put your arm down, it fills the vein right up again. So that's really not an indication that there's surgery required. It just indicates the pectoralis minor muscle, which is right here, is laying on the blood vessel and squeezing it. There are a lot of different tests that can be used. I'm not going to go over those tests, but there are 30 other conditions that mimic thoracic outlet syndrome, from herniated disc in the neck to carpal tunnel syndrome, and ulnar nerve compression, ulnar nerve neuropathy in the elbow, and median nerve entrapment here in the forearm, hyperabduction shoulder compression, and there's diabetic neuropathy, and then you've got anything from multiple sclerosis to MS to MD, and in just a syringomyelia, a Pancoast lung tumor. These all have to be ruled out. The first one is the cervical disc. If you have a herniated disc at anywhere in the neck that causes tingling in the fingertips, you have to say one thing: was there a trauma recently? If there wasn't, then that's probably not the cause of the tingling or the pain. Also, shoulder conditions like rotator cuff syndrome does not cause tingling. Intercostal neuritis, which is a pinched nerve between the ribs, does not cause tingling in the fingertips, doesn't cause swelling of the hands like thoracic outlet syndrome does. So there's all kinds of ways of differentiating whether you have thoracic outlet syndrome or something else. As a matter of fact, you could have thoracic outlet syndrome compression here, you could have hyperabduction in the shoulder causing symptoms. You can have median nerve entrapment both in the forearm as well as in the carpal tunnel area. You could have 4 different conditions at the same time. 2 of them is called double crush. 3 different compressive syndromes is called triple crush, and I've seen quadruple and quintuple crush. So now, vascular compression, such as Paget shoulder syndrome, what it happens is you have a blood clot that causes the arm to fill up because you can't get the blood out of the arm. It expands, and then you have the veins stick out, and you could see a size difference, and the arm feels heavy after activity because you can't get the blood out. It's backed up and it's heavier, and it's swollen and discomfort, and sometimes turns blue. This is a serious problem. You don't want to play with that. You need to get to the hospital right away to get the clot busters to break up that clot in the vein, because if you don't, it can go into the heart and then go to the opposite side lung and cause a pulmonary infarct where your lung dies. And then you're heavy breathing because you can't get the blood in. And so now what I'd really like to go over is some of the treatments. For instance, some doctors do scalene injections with lidocaine and corticosteroids. And we just said that 9 muscles were actually more commonly compressing the entire outlet. So just injecting a couple of muscles does not improve the condition significantly. And then what happens is, well, we tried that, so we're going to try surgery now. That's not a very good attempt at getting rid of thoracic outlet syndrome. Now, also, a lot of therapists like to stretch the neck to the side. Stretching is not for everything, every kind of condition. It's specifically contraindicated for this condition because when you stretch the scalenes, it actually lifts the ribs up even higher and irritates the muscle. Don't ever let anyone stretch you from the side. Botox injections have become popular. And when I say popular, it's like whatever's handy. They say, well, we inject the muscle and then the muscle doesn't contract anymore, like when you inject it into the forehead for the wrinkles. But the problem is that you already have weakness in the shoulder and the neck, and then now you have muscles that aren't contracting for 3 months, and they're significantly weaker. A cast on an arm is 9 weeks, and you could see a significant difference in size and strength from that broken arm. So Botox injections. One time, a doctor thought it was okay because she had sore trapezius muscles to inject the traps with Botox, and then the muscle ceased to contract and it dumped the whole shoulder on the outlet, and she had an arm that was paralyzed for 3 weeks until the Botox actually wore off. So you have different approaches, like the transaxial approach. They come up from underneath the armpit, cut through, and remove the rib that way. Supraclavicular, they come from the front. This is handy when you have blood clots and they have to repair a vein. And then you also have the removal of the cutting of the pectoralis minor, called a tonectomy, underneath the armpit as well. Now, when you remove the pectoralis minor, you say, well, we're keeping the shoulder from being drawn down into the outlet. But as I mentioned, the coracobrachialis and the biceps short head and the subclavius muscles work with the pectoralis minor to drag the shoulder down. You're only cutting one, not all four. So that's incomplete decompression. And if the symptoms come back, don't be surprised after the surgery. So with that, I'd like to talk about my method, which is the first thing I do is I take a powerful vibrating massager and I flush out all the inflammation and lactic acid. As I mentioned, this creates the circuit that keeps the contraction going. So I start by doing about a half hour to 40 minutes of powerful vibration to stimulate the blood flow, to get a river of blood flowing through that area. And then after that, then I do the deep tissue pressure points on those muscles to calm them down so that they will release and open up the outlet. Now, to reprogram the muscle tension, you use the thumb, which is 1 Chinese inch. Now, when you're doing the pressure points on these muscles, if it's on one side, you have 9 muscles. They're all about 4 inches long, so you have 36 points. And if it takes 2 minutes for the point to drop from pain to pain-free, and then move to the next one and the next one, then you've got 2 minutes times 36 points. That's 72 minutes minimum. So that's over an hour and a half with a little bit of a break. The problem is that the business plan, which is the insurance, only covers 45 minutes, maybe a half hour, but the treatment plan is 72 minutes, or let's say an hour and a half. So if you can only get through a few of the muscles and not all 9, it's an incomplete treatment, and that's why these treatment approaches fail. You have to extend the treatment beyond the 30-minute maximum on the insurance to get the full area covered so that you can actually sweep through it once each visit, and then about 10 to 15 sweeps through, then you move the inflammation out. After that's done, you pushed all this inflammation out into the interstitial space, which is the space between the skin and the muscles. That's going to go through the lymphatics. Problem is, the circulation is not very good because the people are walking around like this all the time. So you do that second treatment with the powerful vibrating massage to move the inflammation that you pushed out and get it out of the area so it doesn't seep back in. Otherwise, it'll start right back up again. So these are some of the treatment methods that I use to get these muscles. And you have to lay the patient on the side so you have the shoulder wiggly, and then you put the application of the treatment, like for the pec minor, you're going to have the patient lay on the side and they're going to go up underneath the pec major to get at it. Also, then you have to restore the joint play because the muscles have dragged these, like the collarbone, the AC joint and the acromiosternal joint, where the collarbone and the sternum join together. You have to make adjustments of those bones to get them moving because typically they're jammed together, being compressed for so long. There's scar tissue there, and you have to make those adjustments. Then you must get a first rib adjustment. Now, I don't care what you think of chiropractic, but when the rib is high, you can't do muscle training to pull the rib down because there are no muscles that actually pull the rib down. So I don't care what you think of chiropractors. If either you're going to get the first rib adjusted down out of the outlet or someone's going to cut it out. So I think you'd prefer to have it adjusted down than have it cut out. Now with that, this is my last slide, actually second to last slide. I'd like to mention that what I've found is that because I work in the entertainment industry, is that we started treating patients, like let's say if they're only here 2 days and they're from some entertainment group, They only have 2 days, want to get rid of it at that time. I've treated the patient like, 3 hours in the morning, deep tissue, till noon. How do you feel? I feel a lot better. Go get some lunch, come back, let's work on it some more. 3-4 hours in the afternoon. How do you feel? Even better. Great. Okay, go get some dinner. Come back after dinner. Let's work on it in a couple hours. How do you feel? Wow, I feel really good. Okay, we'll start up in the morning again. Same thing. And what I've found is these treatments actually get the same benefit as if you did them 30 minutes for 3 days a week. You're only working an hour and a half on the thoracic outlet, and you could get an hour and a half in the morning. You get 3 hours in by noon, and you get 9 hours in by the end of the day. So you're actually getting like 50 treatments in 3 days, and we were able to get these conditions resolved to the point where there's no compression and pain in the muscles like there was before. Like when we sweep through, I don't feel anything, I don't feel anything, I don't feel anything. When they used to say, it's killing me, and the nerve sensations are gone after days instead of weeks. So that's the fastest approach that I have found that has worked, and especially good for people from out of town and big business types that don't have the time to be going back and forth to the doctor all the time. Now, with the last slide is that I just released a book on thoracic outlet syndrome. It's a 500-page, 15-chapter book that was released in 13 countries on Amazon. And within the first week, it went to #1. And it went to #1 in several countries. And it stayed there for quite a long time. And so that book is now an international #1 bestseller. So I'm excited about it. It took a lot of time and put my passion into writing it. And there's about $25,000 worth of custom illustrations like you see here at the presentation in the book. There's custom photographs. There's pictures of how you can treat yourself and how you can actually give the book to your doctor or your therapist or your massage therapist and say, could you do it like this? And then there are pictures of me doing the pressure points where they're best applied. So it's a very comprehensive book on thoracic outlet syndrome, and it will help you to figure out whether you have it, what the best approach is, and how to treat it yourself or have someone help you with it. So with that, I would like to thank everyone for inviting me and sticking around for my keynote presentation today, and I appreciate your kind attention. Thank you so much.